Okay, good afternoon. We will get started. Uh, Probably not so very long ago, I don't know, 50 years, sort of like yesterday. Uh, Alzheimer's disease was a name that people knew a bit about, but it wasn't prime time by a long shot. But it certainly is in today's world. And there are many things that have brought that realization about. In the old days, you couldn't biopsy somebody's brain, there were no scans, and so a lot of the information accumulated from postmortem pathologic examinations and then sort of built up. But now, with an aging population, all sorts of factors are there, and certainly there is huge public demand to do something about it. And when that happens, that's usually reflected in people of diverse expertise coming together to put their brains together to try and advance the process. And that's the fundamental purpose of demystifying medicine. So, Dr. Kapogiannis, what is that? Very good. So why would we show the Brooklyn Bridge? I've said this so many times in the past 12 years that many of you probably say, oh, here he goes again. But it's worth repeating because that's the logo. We are on that bridge, the suspension bridge, the walkway that separated Brooklyn, which is where we are, from New York, which was over there. Now, the most important thing about the thing is that when you build a bridge, life is never the same on either side. And the same thing is true in trying to link advances in biological, engineering, mathematical sciences with human health. There may be resistance on both sides of the bridge, but if you get enough people together, maybe drink a few cups of coffee, share knowledge, share questions, good things happen. And that's the purpose of demystifying medicine. Now, what do these people have in common? Well, you could have a long, long list, but these are amongst the many of the celebrities who played a part in the public awareness of Alzheimer's disease. Often the celebrities play more of a role in focusing on medical research than we give them credit for. But these are some of the ones who certainly their illness attracted personal public attention. So one of the questions that people ask, both in the medical profession and also amongst the public, do I have Alzheimer's disease? I can't remember the name of my high school English teacher. I'm not sure about my mother's maiden name. And who is my current tennis player? Are these symptoms of Alzheimer's disease? Where did I leave my car keys for the 5th time this month? And where was I supposed to meet my wife this very evening? What's the borderline between forgetfulness and Alzheimer's disease? People who can't answer those questions, particularly lay people, become very concerned that am I on the way toward this irreversible and so forth and so on. So how do you diagnose Alzheimer's disease? We still don't put, like liver, you can put a needle in and take out a piece, but you can't do that so easily inside the cranium. So are there blood tests? Are there gene profiles? There are families in which Alzheimer's is very common. Does that provide a genomic clue? And where do brain scans fit in? Are they specific? Are they diagnostic? And should I have a brain biopsy? And most importantly, I guess, what's the mechanism? And from a patient point of view, what's the prognosis? I'm 40. I wish I were. I'm 80. I wish I were 82. I'm 95. No, I'm not 95. But does it make a difference how old you are when these things happen? So we are really delighted today to have two experts discuss these and other problems and encourage your participation. Okay? So our first speaker, Dr. Kapogiannis, graduated from medical school in Greece and was trained in neurology, and then ultimately came into the arena of the NINDS and was interested and expert in cognitive, particularly in cognitive neurologic disease, of which Alzheimer's is perhaps almost one of the very best known. So why don't you begin, and then we will continue, and we're very grateful to you for coming. And these are all scientists, some young, some a little older, and they're interested in what
Are you going to speak to him after? I will speak a few slides, then discuss with the patient, and then show some more slides. So I'm grateful for this introduction, and I'm grateful to everybody for coming to this event. Dr. Mattson and I will make an effort to shed some light in some aspects of Alzheimer's disease, although to demystify such a complex disease, it's rather too ambitious, and or maybe we can actually highlight some of the mysteries that surround this disease and may explain why we don't still have a cure to it. So there is one peculiar aspect to Alzheimer's disease, and that is that it really, when we use the term for Alzheimer's disease, we refer to two different entities. One is a clinical syndrome, and I will say a few words about this clinical syndrome of Alzheimer's disease. Then I will move on to discuss with my patient and his wife, and then move back to say some few words about the other aspect, which is the clinical pathological entity. And so the clinical syndrome of Alzheimer's disease is a progressive impairment in memory. And in order to have a framework in our mind, I will refer to the different types of memory that may or may not be affected in Alzheimer's disease. So there are different memory systems in our brain, and cognitive science has classified them in different entities. A first big distinction is between procedural memory and episodic and semantic memory. This is considered non-declarative. In other ways, it cannot be verbally reproduced by the person. What do you remember when you do it? And typical examples is overlearned behavioral patterns and motor programs, such as driving a car without paying attention while you're doing it because you actually have overlearned it and you know how to do it, or learning a motor sequence of numbers. This type of memory is considered hippocampus independent and is not vulnerable to Alzheimer's disease. In fact, even if we take out the hippocampi bilaterally, this sort of memory can persevere, and even an HM patient has that type of memory. The other type of memory is working memory, and working memory is declarative. You can have knowledge and awareness of having it, but it's a short span of keeping a small amount of information briefly in memory, rehearsing it in your head. For instance, when you are trying to rehearse to remember a number, a phone number, and you keep on repeating the sequence in your head, this is working memory. This is considered predominantly something mediated by the frontal lobes, and to some extent may be affected later on in Alzheimer's disease. But really, when we're talking about Alzheimer's disease, we're talking about episodic and semantic memory. And episodic memory is memory of events, and semantic memory is memory of facts. And what do I mean by that? Events are something that have a beginning and an end in time, and they involve specific details of what, when, where, and context of a particular event. Semantic memory is a memory of facts. You may have learned some things at some point in your life, but really, if I ask you, who is the President of the United States, or when the Declaration of Independence was signed, you may or may not remember the very first time that you acquired this information, that you heard about this, but it has been repeated so many times over the lifetime that it really doesn't, it's not tied anymore to any specific when, where, that you have this memory. So these are kind of some classic definitions that I want you to keep in mind because they're gonna shed light about why I'm asking some questions and how our participant here will respond. I have to say that these classic definitions we continue to evolve to our understanding. So one particular aspect of memory that I will focus on my questions is autobiographical memory, the memory of our life story. And again, this autobiographic memory has semantic aspects to it and episodic aspects to it. Episodic aspects of our autobiographic memory are specific events that we may remember. Semantic is facts about ourselves, about our life. So if I ask someone, what's the name of your wife, or do you have children? This is the kind of fact that we know about ourselves, and it's really not an event in time that you have children. You either have or you do not, and you either know about it or not. So, and also some, as research is evolving in the cognitive aspects of Alzheimer's disease, we come to realize, for instance, that there is another side to that, and this is remembering the past. But closely to that linked is also imagining the future. So memory of the past and the imagination of the future are actually two processes that are linked in our brains, and they use the same networks, and they can both be either vague or concrete in time. So with that in mind, I will just engage into a dialogue with my patient here, Mr. Cummings. Mr. Cummings, I have to clarify this, is graciously agreed to participate in this event. Mr. Cummings faces some problems with memory, but I want to emphasize that I want to dispel the notion that it is black or white, all or nothing, that there are many intermediate zones when people are having some memory problems and some general cognitive problems and yet be able to function otherwise very well. And in particular, in the stage of mild cognitive impairment, one may have evidence of Alzheimer's disease pathologic process, but the cognitive profile may be such that overall there are compensatory strategies and be able to adapt to the difficulties. So Mr. Cummings, thank you for coming again. So I would like to ask you first, you shared with me that earlier in life, currently you are how old, sir?
83.
83. You had shared with me that in your 60s, it was the first time that you had some memory problems. Can you tell us about that time?
Well, I started losing my memory, at least I thought I did, to the point where it actually got to the point if I was having a conversation with you, I had to have a prop to remember who I was talking to or what the subject was. So I had a 3x5 card, and I would surreptitiously make notes. I'm a consultant. I operate a national consulting firm. And if my clients knew that I couldn't remember, I don't think I'd get a lot of business. So I worked very hard at hiding, if you would. But I was able to keep going with these props.
Was there anything else going in your life at the time that may have played a role in that?
Yeah, a couple of things. My bride here, long-term wife, mother of my children, thought I was getting old. Well, I was taught, and I believed until fairly recently, that memory, like strength, is something that dissipates over life. And so it's a logical assumption on her part. And my daughter, who lives in England, came home, hadn't seen her in 4 or 5 months, and after about 5 minutes, she says, "Dad, you're depressed." What is depression? I'd never really thought about depression.
So can you elaborate a little bit, and why could it be that depression had played a role at that early time?
Well, when my daughter first hit me over the head, if you would, with "Dad, you're depressed," it woke me up, and I immediately started a rigorous, I went to a psychologist, a sociologist, a theologian, all of the people you can think of. And the short story is that I had recently been, before my memory started to disappear, I had a back x-ray, and there was something on the top of the x-ray that the doctor said, "You ought to look at this." And what it was thyroid cancer. And the doctor said, "It's going to kill you. We have to kill it." And we did all of the appropriate things. And we do a periodic needle biopsy to see where it is. But what I now know, this is all after my daughter talked to me, that the type of cancer I have, despite the fact I took it out, it's going to come back. And it is going to kill me sometime in the next 50 years. And it's slow acting. Well, given that information, why should I even worry about it? Remember it, monitor it, but not worry. Then, because my memory was bad, I tried to get into an NIH memory impairment study. After 3 days in Johns Hopkins University Hospital, they documented that, boy, my memory was really bad. And about that time, my brother died. Fast forward, those 3 things was subliminally consuming my brain power. And when I realized that my thyroid cancer was irrelevant to today's existence, that my brother's death was unrelated to me, the NIH study showed that I had a heart condition that if you look at my EKG, you will rush me to the emergency room. But what they didn't know is I was born with that. And for whatever reason in my body, it is totally insignificant. Well, when I have NIH doctors tell me that I have a funny, bad heart, I won't last the study, that really got to me. But now I know, I get pointed out, I've had it forever.
Can I make a comment? So I wanted you to go back in time because apparently 20 plus years ago, people thought, well, you have what we would call dementia, and they had pretty much written you off. But that was not the right assessment. And it was not the right assessment in the setting of depression. And so as a clinician, there have been times that I have been fooled, underestimating the cognitive abilities of a particular person, and almost always the culprit is depression. So depression can make everything appear much worse, and it is a cautionary note for clinicians to always investigate it and, if possible, treat it. It sounds like that you treated it almost by yourself. Did you take antidepressants at the time, or it was more a cognitive reassessment?
I had probably 3 weeks of antidepressants. I had probably 3 months of dialogue with professionals. Mm-hmm. Basically putting my head straight.
Okay, so let's get fast forward. But again, something changed in the last 2, 3, few recent years, right? So you had this depression in the past, you overcame it, your memory improved, but then something else started changing more recently. And so let's focus on that now.
I think there's 2 things. One, I'm getting older.
Okay.
And by being in a study with the doctor, I had every other month fairly exhaustive medical exams, MRIs, the brain, etc., tracking what I can't understand, all the things that are happening in my head.
But let's focus a little bit on symptoms you may be facing. Are there, did you start forgetting events that have taken place or details about events?
I'll make 2 answers to that. Yes. Let me go off in a sidebar. I talk to a lot of people, particularly older people, and when I tell them my story of my daughter waking me up, it kind of opens their eyes too. I'm of the philosophy, Dr. Cummings with no credentials, that we allow things that are going on around us to influence us to degrade our performance. And I kind of was led to believe earlier, as I get older, I'll be less and less capable.
Okay. But let's focus a little bit on some difficulties, and then you will tell us how you fought back and overcame these difficulties. Perhaps I should turn to your wife to give us some examples of...
Well, first I would start that Lake has always been a little bit of an absent-minded professor.
Okay.
Always. But also, this is the face of today's Alzheimer's. He still works over 40 hours a week with paid and volunteer work. Now, that's down from his 80 hours a week. I have age-related dementia, so I always make notes. He's the president of the condo board, and he took on a problem condominium, and he's increased the values and done a lot of things for our properties. He handles all our rental properties, and he usually can fix my computer. Let's see. He's got his own personal business, finance, health. He does his own health. He knows about diet. He does his own exercise program. He does all the things that are going to supposedly disappear someday.
But it's taking longer every day.
Oh, also he drives. He still will insist on driving the whole way on a 12-hour trip. Now, we both use the GPS to go to church, but that's a different story. And he does, his memory has deteriorated in periods of stress. We downsized, which meant he had to get rid of those 20-year-old piles of mail. So we had to do that, and he's had some medical issues. But usually he's come back. But he does have some holes. The 2 big ones, I would say, are finances and and to a lesser extent schedule. Finances, I don't think he knows how he could tell you. If you gave him 2 weeks, I still don't think he could tell you what he made last year because we haven't done our taxes yet. He's still working on these things. He's got all the pieces of paper, and maybe they'll get put together. But doing things like that are not part of his skill set right now. I found that he was not paying some of his charge cards. We had a complicated case where we had to cancel a charge card. I had to do some of the walkthrough on that.
Let me actually ask some specific questions because it is remarkable. The strengths are remarkable here, and the strategies to compensate are remarkable. But if we don't offer the few holes that you mentioned here, the audience will not get
well,
the point.
So, I handle the finances, yes.
So are there any recent events that he may forget or details of recent events that he may forget?
Well, it's interesting because I was trying to figure this out. He's always been very good at telling his story. They may not be literal, but they're always the same story. I've noticed that I may have seen things differently if I had been there. But I've noticed there have been a couple times where, like our story of meeting, we used to meet at the top of the ski slope. Last couple times we met at the bottom of the ski slope. So I am noticing some problems in that area. But this has not been a problem for us because they haven't been in critical areas.
Okay,
So, he forgets things. But we've always had something else left to talk about. It's not these big holes where he repeats the same thing 10 times in dinner. We don't have any of that going on at all.
Actually, this is very interesting that you said, and makes the point that memory, every time that you tell a story and you recall an event, you reconstruct it from its elements. And this reconstruction, there has always a creative component to it. And there are sometimes what we call false memories that get into the combination. So if the real story was like that you met on the top of the slope, as you said, there can be, this is called the false memory, the bottom of the slope. So anything else more recent about recent life? For instance, if you have an activity together, meet friends at a restaurant, and then you talk to him later on about this, would there be any mistakes there? Or?
Well, yes, but that's why I say it comes and goes. If you said this to me 2 years ago, he was having a lot more difficulties with that then than he has in the last year.
Examples?
I think, well, I remember once somebody had just told us something, and 15 minutes later, he's telling me the same story, but it didn't come from the person that just told it to us 15 minutes ago. I was noticing a lot of that a couple years ago, but he's had some health issues that have been corrected. Mm-hmm. And like I said, we've moved to senior housing. He's had, I'm not saying his office is organized, but the piles are only 2 years deep, shall we say, So I think that the simplification and his exercise program and his medical stuff and the fact that he pays attention to this stuff and that he is now back working for about 2 years, or for when we were moving, he did not have time to do his consulting work. This is his lifeblood. And now that he's doing that, his memory for everything has improved.
Great, fantastic. So let's. So you gave us a great account, not only of difficulties, but of how one can overcome these difficulties and fight back. So thank you. I will say a few more slides.
So perhaps one question.
So
Yes.
what was the,
Sir.
you mentioned you have some cardiac issue. What was the disease? Is it atrial fibrillation causing emboli to the brain and causing multi-infarct dementia?
Quick.
I think it's a monkey link. I'm mispronouncing it. I have an unusual heartbeat that would signal problem. That's not, for me, a problem.
Okay. I think,
Okay, I was just
Yeah.
going to say he also had a stent put in 6 months ago, so he's had other medical issues on the heart. Yeah.
Okay,
all right, listen,
So-
we want to thank you.
Okay.
thank you.
And wish you the very best. Please sit down. And,
So I mentioned before that Alzheimer's disease is has two options, two sides to it. One is the clinical syndrome, and then is the neuropathological entity. So the neuropathological entity has a macroscopic component and a microscopic component. So the macroscopic component is what we call atrophy, the progressive shrinkage of the brain. And here is a textbook image, and in all textbook images, you always select the most telling signs, and this is the most extreme cases. And so this is a normal brain, and this is a brain with Alzheimer's disease. But in real life, it's not as clear-cut, and there are many cases of intermediate atrophy, which actually it's hard to tell if it is normal aging or Alzheimer's disease. The microscopic components of Alzheimer's disease are twofold. They are the accumulation of an abnormal protein called amyloid beta extracellularly. And this accumulates in what we call plaques, neuritic plaques and other less well-organized plaques. Plaque is an accumulation of a beta surrounded by dystrophic neurites and abnormal synapses. And it is being distributed in the brain in a characteristic pattern that involves a lot of many areas of the cortex, in particular areas of the cortex that receive input and project output to many other areas. Relatively preserved are areas of the cortex that are involved in primary modalities, primary motor cortex and primary sensory cortices are relatively preserved. And particularly vulnerable are areas in the temporal parietal junction region and the precuneus, an area in the middle posterior of the brain. The other component to Alzheimer's disease is tau. It's a protein that accumulates intracellularly, and it has a very different pattern of accumulation in the brain. Tau is deposited predominantly and early in the hippocampus, the temporal pole, and has a very different pattern of accumulation. And in fact, if I show you both, you will be able to appreciate how much different this pattern is. There are some areas where the two pathologies overlap, but some areas where there is a great mismatch. For instance, the hippocampus is an area that has a lot of tangles and early on, whereas it has very few plaques until much later in the disease. So one of the key mysteries to Alzheimer's disease is how is it possible to have one entity with two different pathologies, plaques and tangles accumulating at different parts of the brain. And no good account for that has put forward to this day. I will skip that. Few years ago, Dr. Mattson and I tried to put together some abnormalities, and I'm putting this slide there to organize our thought. So we have manifestations that are clinical manifestations, pathology, and then something in the middle to bridge them together. So the earliest clinical manifestation is subjective cognitive impairment, and usually it involves memory. It's the feeling that something is different in memory, in episodic memory. Then we go to the stage of mild cognitive impairment when most cognitive functions are well compensated, but there is some progressive and persistent memory problems. And Mr. Cummings gave you a good account of actually MCI, where you have some focal problems, but also compensation for those. And then some people with MCI, not all of them, may progress into Alzheimer's dementia when there is progressive memory failure and cognitive failure that affects functional ability, which is no longer compensated. In terms of pathology, though, the very early pathologic changes before any symptoms, it's a progressive accumulation of amyloid beta in plaques in the brain in this kind of pattern that I showed you. These plaques accumulate over time, and they spread from the initial focus into other areas of the cortex, and then progressively you start seeing accumulation of tangles, which is a downstream event, and as well as synaptic dysfunction and other, and eventually that proceeds to see synaptic and neuronal loss. And at the stage of Alzheimer's disease, you have progressive synaptic and neuronal loss that corresponds to the atrophy that I showed you. So what I wanted to emphasize is that there is a continuum of symptoms, a continuum of pathology with many things happening at the same time. And I will let the stage now to Dr. Mattson to discuss more the what basic science can teach us about this disease. Thank you.
Thank you, Dimitrios. I have a couple of short questions.
I think I heard you say that because of the different localizations of beta amyloid and tau, you would expect different symptomatology.
So what I actually wanted to draw attention to is to the fact that it is not always prominent in the mind of people when they are thinking about Alzheimer's disease. And that is the fact that we know that there are two different proteins that are abnormal and accumulate, but they are not really in the same place. There are areas where you have accumulation of one, areas where you have accumulation of the other, and their overlap is not very good. So that's a big mystery in Alzheimer's disease. I personally think that this is perhaps one of the keys to understand. If we understand why this happens, I think that will be an important leap forward. The second point that you brought is how does this relate to symptoms? And of the two pathologies, tau, the accumulation of tau, is the one that predicts symptoms. So when you have accumulation of tau in a certain area, then you're going to have impairments to the function of this area.
So how do you diagnose Alzheimer's disease when you're in the middle of the spectrum, or do you diagnose it?
So that's why I referred to it's a unique disease because it has the clinical syndrome and has the neuropathologic component. So there is the old provisional wisdom that that Alzheimer's disease cannot be diagnosed before death. Well, what people used to mean by that is that if you want to diagnose the neuropathologic entity, you need a piece of brain tissue to do so, and that is only available after death. So that's what it was really meant. But if you want to diagnose the clinical syndrome, well, the clinical syndrome has specific clinical features that you can recognize by history and by the cognitive exam. Plus, now we have biomarkers. So recently, the NIA and the Alzheimer's Association put together task forces that brought the concept of high probability Alzheimer's disease at the stage of MCI. So you can have mild cognitive impairment with high probability Alzheimer's disease if you have evidence of A beta or tau accumulation in your brain. And this is in terms of PET scans that detect amyloid beta and tau, or these proteins in the CSF. So now you can, it is acceptable to diagnose it in life.
Okay,
Thank
so
you.
we'll return to you, Dimitrios, after the presentation. Okay, so our second speaker is Mark Mattson, who got his PhD at the University of Iowa and then became involved in developmental neurosciences at Colorado State University, and eventually became a professor, full professor at the University of Kentucky Research Center on Aging. Mark is one of the global leaders in the area of cellular and molecular mechanisms underlying neuronal plasticity and neurodegenerative diseases. And I would urge you to read the material. By the way, everything that's presented in this course is on the website for the past 12 years, if you wish, and also appropriate reading materials and some suggestions so you can follow through further. Mark is the chief of the Laboratory of Neurosciences in the National Institutes of Aging, and we're very grateful to you for being with us today.
Thanks, Win. Whoops. Okay, that was my talk in reverse chronological. Just for any of you interested, if you're like Mr. Cummings, maybe has mild cognitive impairment, if you have relatives who've been diagnosed with probable Alzheimer's disease, the National Institute on Aging is the main institute at the National Institutes of Health that focuses on Alzheimer's disease research, and you can easily find them on the internet and get a lot of information there, as well as the Alzheimer's Association. And Wynn pointed out, he put up a list of famous people who had dementia or Alzheimer's disease, and at the top of the list was Ronald Reagan. And as an interesting personal story, I'm from Rochester, Minnesota. I went to high school at Mayo High School. Okay, Rochester is where the Mayo Clinic is. Ronald Reagan's doctor is Ron Peterson at the Mayo Clinic. My father, when he was about 84, was clearly having short-term memory problems. It was very obvious in phone conversations, a 5-10-minute phone conversation. He would repeat something several times, forgetting that he'd already asked me that question. So we took him in to Ron Peterson, and I'd known Ron Peterson for years. And he was diagnosed with probable Alzheimer's disease, which is the diagnosis that's given based on the clinical, doing the cognitive testing, and even the imaging isn't a clear diagnosis, because Alzheimer's disease is defined by the pathology at autopsy. And there are many different types of dementia that don't involve massive accumulations of amyloid in the brain. And my father was one case. So Ron Peterson diagnosed my father with probable Alzheimer's disease, and then he progressively declined his cognitive function. He passed away at the age of 90, and they did autopsy on his brain. He had massive loss of neurons in the hippocampus, this brain region that's critical for short-term memory, but he didn't have a lot of amyloid. Okay. So anyway, that's a personal note. What I'm going to do is I'm going to most of my talk's going to be on a positive note, and it maybe follows up on Mr. Cummings' case where, according to his wife, he exercises regularly, which is what he should be doing. Keep it up. Keep it up. And I'm going to also tell you that we think that some of the major risk factors beyond aging for Alzheimer's disease are the same risk factors for cardiovascular disease, diabetes. Being sedentary, overeating, being overweight, and constant state of chronic excess energy intake. And in the case of your brain, couch potato, sitting in front of the TV, watching TV, not engaging your neural networks in a rigorous manner. So not being intellectually engaged. So you need to keep exercising, moderation in energy intake, keep your brain active. Right. So we're trying to understand, on the one hand, how some people, as they get older, and maybe Wynn's a good example of that, his brain seems to be functioning very well. So he's going this way. Actually, we don't know with Mr. Cummings. I don't know. I was actually impressed. You know, he's based on the cognitive testing. Apparently, he's diagnosed with mild cognitive impairment, but he seems to be compensating. And you know, exercise may be one thing, and keeping your mind engaged is very important. So keep the spirits up. That's very important. But many people, you know, because of there's genetic factors too. For example, apolipoprotein E4 allele may increase your risk. But there are genetic environmental factors. So I'm going to focus on the environmental factors, diet and lifestyle, that may determine whether an individual goes this way during aging or ends up with dementia. I should also point out that you know, aging is the major risk factor for Alzheimer's disease as well as Parkinson's disease, and the National Institute on Aging focuses a lot on basic mechanisms of aging that may predispose one for many age-related diseases. Many of the diseases that these other institutes study, for example, deafness, that's a problem that increases with aging. Heart disease increases with aging, the Heart, Lung, and Blood Institute. Diabetes and kidney disease, same thing. Cancers, your risk for cancers increase with aging. So the processes that are occurring in all cells in our body during normal aging increase the risk for these age-related neurodisorders, disorders including neurodegenerative disorders. Now, there's been advances in the early diagnosis and treatment of cardiovascular disease, many different types of cancers, diabetes, such that many people who would say when they're in their 50s or 60s would have died from a heart attack or, you know, didn't have their cancer diagnosed, didn't get a colonoscopy or whatever, you know, they're now living into the 60s, 70s, and 80s. This age range is the danger zone for Alzheimer's disease. Okay, it's very rare for people in their 50s or 60s to get dementia. There's some inherited cases, but for the most part, it's people in their 60s, particularly 70s and 80s. And this is the age distribution of the US population in the years 2010, 2030, and 2050. So you see in these early ages, there's a relatively small increase in the number of people in their 20s, 30s, 40s, even into the 50s, but there's a huge increase, a doubling of the number of people in this age range. We have no effective treatments for Alzheimer's disease, Parkinson's disease, or really stroke. So we really need to focus on education and what people can do during their adult life to reduce their risk. You know, we can be hopeful, but I'm knowing what's going on in the brain with nerve cells dying. I'm not terribly optimistic in the near future that we're going to have a drug that someone whose short-term memory is gone, that you give them a drug and all of a sudden they're fine again. Okay, so I'm going to quickly go through what we think is happening in nerve cells in the brain during aging and how these age-related changes in people who, because of who they chose as their parents or their diet and lifestyle, may exacerbate these age-related changes. So nerve cells have problems in generating enough energy, ATP, in their mitochondria. That occurs during normal aging. It's greatly exacerbated in Alzheimer's disease in the vulnerable brain regions. Neurons have problems regulating ions, particularly calcium, which is a very important signaling molecule at synapses. There's increased free radical damage, oxidative stress, DNA damage, impaired ability of the neurons to remove damaged or aggregating proteins such as tau, which Dr. Kapogiannis mentioned, or amyloid beta peptides. So these accumulate in the brain a little bit with normal aging, but much more so in Alzheimer's disease. And then importantly, the ability of nerve cells to deal with these stresses that they're experiencing during aging is compromised. And I'm going to talk about how exercise, dietary energy restriction, particularly fasting, intermittent fasting, and also keeping your nerve cells active may bolster these adaptive stress response pathways and protect cells from these changes that occur in their ability to generate energy and deal with damage. Okay, now this is just some epidemiological and demographic data that raise a lot of concern in my mind for the future of brain health in the elderly in America. So, as many of you know, the southern states, there's increased obesity, increased incidence of diabetes, stroke. Their life expectancy is lower. Cancer, more common in people in these southern states and up into Kentucky, Tennessee, West Virginia. Interestingly, if you look at neurological disorder mortality, which is mainly stroke and Alzheimer's disease, there's some increase in these regions. But if you look, what this lower right graph is, it's the increase in the mortality rate from neurological disorders between 1980 and 2014. So there's been a big increase in brain disorders, and these are mainly age-related brain disorders in the last 30 to 40 years in the South. So, and now we know from many other studies in humans that individuals who are chronically overweight, and particularly those with type 2 diabetes, are at increased risk for cognitive impairment and dementia and stroke. Okay, so let's go back in time even further. Childhood obesity, the hot spot is in the same regions of the South. So these kids are not getting as much exercise, and they're eating a lot of high-calorie, high fructose corn syrup food. Women diagnosed with diabetes, again high here. Interestingly, if we just look at general indicator of brain function, a one measure anyway. This is again demographic. High school graduates, much lower in these same states where there's obesity and diabetes, childhood obesity and diabetes. College graduates, much fewer in the same regions. Okay, so this doesn't bode well for the future of these kids, not only for their heart and increased risk for cancers, but we think also for their brains. So now if we look at energy metabolism, the nerve cells in your brain use mainly two sources of energy. One is glucose, and the other is ketones. Okay. Patients with Alzheimer's disease and even patients with mild cognitive impairment have reduced the ability of their nerve cells to use glucose. And this is demonstrated by positron emission tomography. So the bright color here means that the nerve cells are using glucose. The blue or the decreased amount of red indicates that the nerve cells are not able to use glucose. And we did some studies 20 years ago where we showed that the amyloid beta peptide, which accumulates in Alzheimer's disease, will impair the ability of nerve cells to take up glucose from the, in this case, culture medium. So in Alzheimer's disease, there's impaired ability of neurons to use glucose. However, we think that the nerve cells can still use ketones. And here's some data showing where they put subjects on a ketogenic diet. So this is pre-ketogenic diet looking at utilization of ketones. So blue is low level of ketone utilization, red is high. So you put someone on a diet where they have essentially zero carbohydrates and they have low blood glucose but high blood ketone levels, the brain cells use the ketones, okay? And then in this review article, Dr. Kunan, he showed that even in patients with Alzheimer's disease, if you plot the amount of ketones their brains can use as a function of the amount of ketones in the blood, there's a nice linear relationship. So we think that even patients with Alzheimer's disease, the nerve cells that are still surviving can use ketones, and that may improve their function. Okay, one of the best ways, or most quantitatively greatest way to increase ketones in your blood is by fasting, that is, not eating. Okay, if you're overweight and obese, not eating is a good thing. You will lose weight, and that will increase ketones in your blood. So I'm going to show you some data talking about how exercise and energy restriction, particularly fasting, are beneficial for the brain, and mostly in animal studies. And then at the end, I'm going to talk about some human studies that we've done and are ongoing. So what happens when you fast is, normally when you eat a meal, the carbohydrates in the meal, then the glucose goes into your liver and it's stored in the form of glycogen. And that's always used first. So then when you fast, the glycogen in your liver is depleted. Then what happens is you start burning fats. You start using fats. So fats are released from your fat cells. They go into your liver. They're converted to ketones. The ketones then go into your blood, and they can supply energy to your nerve cells, to your muscle cells, and so on. So we know that humans can fast for a long time period. Weeks, months. There's even a couple documented case studies in morbidly obese subjects who have fasted for a year under the care of a physician. What I'm going to talk about is short intermittent fast. So for example, fasting 2 days a week, or not even complete fasting on those days. Cutting back calories to 500 calories a day, a couple days a week. I'll also briefly talk about another approach, which is each day compressing the time window one eats into, say, a 6 to 8 hour time window. It turns out most Americans, when they get up, they eat something. They eat lunch, they eat dinner, eat snacks, they eat something before they go to bed. The only time that they're fasting is when they're sleeping. And that's not enough time to deplete the glycogen stores in the liver and increase the ketone levels. So most Americans eating 3 meals a day plus snacks, they never have elevated ketone levels, and they tend to have higher blood glucose levels than is ideal for health. Okay. So we've shown in our animal studies that exercise, running wheels in the cage of animals, or treadmill exercise, or intermittent fasting, we typically do alternate day fasting in the animals. One day they have no food for 24 hours. The next day they can eat as much as they want. When we keep the animals on that kind of diet from when they're a young age, they live up to 30% longer. So this isn't a trivial effect on aging and lifespan. It's a huge effect. And we find that their brains function better. I'll show you some of the data. And we've used some of our mouse models of Alzheimer's disease in which the mice accumulate amyloid extracellularly and accumulate tau, that is, these neurofibrillary tangle-like changes in the nerve cells. And I'll show you some data where we find beneficial effects of this alternate day fasting. And I'm going to talk a lot about mitochondria, which are the organelle in the cell that produces the energy, which is particularly important in neurons, which are constantly active and have a very high energy demand. So anyway, the point is here is that we've been working over the last 20 to 30 years elucidating what happens to the brain with exercise, energy restriction, also energy excess. We put animals on a McDonald's diet and find that that has bad effects on the brain, including accelerating accumulation of amyloid and cognitive impairment. Okay. Anyone who's a biologist should understand evolution, and there's always an explanation for how our bodies and brains got to be the way they are. Imagine, if you're an animal in the wild, or our human ancestors, say hunter-gatherers, particularly hunters, and you haven't been able to obtain food for a few days, okay? So you're hungry. It's very important that your brain and body be able to function at a high level under that condition. Otherwise, you're not going to figure out how to find and hunt down and expend a lot of energy to catch your prey. Okay, so it's intuitively obvious that individuals whose brains and bodies function well in the fasted state were at a survival advantage. They were more likely to get their food and survive and pass their genes up. So let's go up the evolutionary scale. Let's go to our, in human evolution, and the human brain, the higher cognitive functions of the brain, I can make a strong case, I think, that even human things like creativity, being able to invent things, imagination, the driving force was the need to obtain food under conditions of limited resources. The first tools invented by humans all had to do with obtaining food. Okay, so inventing bows and arrows. Okay. If your brain had evolved enough you could do this, you survive. If you weren't able to figure out how to invent a bow and arrow, you die. Okay. So let's go to animal studies. What I'm going to show you quickly in this study, this was done by a former graduate student in my lab, Alexis Stranahan, who got her PhD through the NIH Graduate Partnerships Program. So she got her PhD from Princeton, but did her dissertation research in my lab at the NIA in Baltimore. In this study, what Alexis did is she took normal mice, which we call wild-type mice. These are healthy mice. And then we had diabetic mice. These are mice that have a mutation in the leptin receptor. Leptin is a hormone. When you eat a meal, it's released into your blood, and it goes to your brain and tells you to stop eating. These mice do not get the stop eating signal because they have mutation in the leptin receptor. They don't stop eating. They become obese and diabetic. And then, so what Alexis did, she maintained these mice under 4 different conditions. The normal conditions for lab animals is they're fed ad libitum, that is, they can eat as much as they want whenever they want, and they're relatively sedentary. They're in small cages with no running wheels. Then she had a group that was fed ad libitum, but they had running wheels in their cages. So this is eating as much as you want, but exercising. And then she had another group that she reduced their daily calorie intake by 40%. And actually, it turns out when you do this, the animals eat all their food within about a 5 to 6 hour time window, and then they're going 18 to 20 hours with no food every day. And then she had a group, both the energy restriction or short-term fasting and running. She had them in those conditions for 3 months, then she killed them. She took out one hippocampus, and she counted the number of synapses on the neurons in the hippocampus. And the synapses are shown here, these perpendicular projections from this dendrite, that is the part of the neuron that receives information from the preceding neuron in the circuit. These perpendicular projections are called dendritic spines. They're synapses. So what you see is that both the energy restriction and the running increase the number of synapses. And the combination of energy and restriction and running, there was an additive effect. Okay? So in as much as that the number of synapses is related to the cognitive ability of mice and humans and their ability to figure out how to find food, being on a calorie-restricted diet and exercising regularly increase the number of synapses. This is in the normal mice. In the diabetic mice, you see that they have fewer number of synapses to start with, but nevertheless, so diabetes is not good. It decreases the number of synapses. But if you do have diabetes, and you're a mouse anyway, and you exercise or reduce your energy intake, it will increase the number of synapses in this brain region that's critical for learning and memory, and that's particularly adversely affected in Alzheimer's disease. This bottom graph, in the other hippocampus, your brain, there's 2 hippocampus in your brain. So Alexis counted synapses in one hippocampus. She took the other hippocampus and measured levels of a protein called brain-derived neurotrophic factor, BDNF. BDNF plays a critical role in learning and memory. It promotes the formation of new synapses. It also promotes the production of new neurons from stem cells in the hippocampus. We all actually have stem cells and can produce new neurons in the hippocampus. It turns out that Dr. Henriette von Prague, who's an investigator in my lab, she had shown that exercise will increase the number of neurons in the hippocampus in mice. And we found that intermittent fasting also does that. Okay, let's go back to humans. Higher body mass index, which isn't necessarily a measure of obesity, but on average, people with higher body mass index are more likely to have higher fat, and particularly belly fat. This shows that the bottom line is there's a negative correlation between body mass index and performance in several different tests of learning and memory in young adults. And again, I go back to this point that our children, it's not good for them to be sedentary and overweight. When they get to be 60, 70, and 80, they will be regretting it from the standpoint of their brain. Okay. 10-year-old, this is interesting. Overweight mothers. There's emerging evidence that it's not good for your offspring. It's been shown pretty clearly in animals, but there's also some epidemiological data that being overweight and obese during pregnancy may not be good in the long term for your offspring's brains in terms of cognitive function. Same with diabetes. Type 2 diabetes is not good for brain function. So there's many studies you can find on that. There are very few studies asking the question if and how exercise and energy restriction impact cognitive function. There are a few emerging, and Dr. Kapogiannis is the principal investigator on an ongoing trial that I'll briefly mention. But for example, there's this study where they put older subjects on calorie restriction diet and found that it actually increased the size of certain parts of their brain that are important for learning and memory. They also did some memory tests. Okay, so let's go. Here's some interesting data, very recent unpublished data. We have these same 4 groups of mice. These are normal mice, either ad libitum sedentary, alternate day fasting sedentary, ad libitum exercise, alternate day fasting exercise. In this case, the exercise is treadmill training. So Keelan Moel, who's a post-bac fellow, and Christina Morosi, who's a postdoc fellow, what they did is they either did not exercise or exercised animals for a month daily on a treadmill for 45 minutes, and every week increased either the speed of the treadmill or the incline. So, and then at the end of the month of training, they tested their endurance and how long can the mice run without giving up. And what they found, as you'd expect, both groups that had treadmill trainings performed much better than both groups that had no training. However, the group of mice that were on the alternate day fasting diet during the 1 month of treadmill training had better endurance than the animals that were eating every day during the treadmill training. So intermittent fasting during exercise training enhances the training effect. And actually, humans are applying this now, and you'll find in the coming years and decades that there'll be a big switch in how endurance athletes train and perform. They'll be doing it in ketogenic state.
Your time periods,
In-
days or
yeah.
hours?
In the mice, what we're doing, it's very controlled. One day we go into the cage and we remove their food. Then the next day at the same time, we give them back food. So they go 24 hours no food, then 24 hours food, 24 hours no food. I'm going to tell you, our human studies, we're doing things a little different. We're having the human subjects either 2 days a week eat only 500 calories on those 2 days. The other days eat normally and don't overeat. Eat healthy. Or each day narrow the time window that one eats to 6 to 8 hours, so that then you're fasting for 16 to 18 hours every day. And again, from an evolutionary perspective, this is very normal. From modern post-agricultural society, what's normal is 3 meals a day plus snacks, but that's not how we evolved. Okay. And how am I doing on time? I'm doing okay. Okay. Right. Okay. So then, in the same study where the animals that were on alternate day fasting during treadmill training had better endurance, we took blood, measured ketone levels, and what we find is that the animals on alternate day fasting that didn't exercise, they have higher ketones on the days they're fasting, which we knew that already. Well, interestingly, the animals that are treadmill training and on alternate day fasting have the highest ketone levels after the training period. So from the standpoint of ketones, you get a boost by combining the fasting with the exercise. Then what we did is we tested their VO2 max, and both groups of animals that trained on the treadmill, their VO2 max increased compared to the sedentary animals. And we actually didn't see a significant difference between the alternate day fasting there. But what we did see when we look at what's called respiratory exchange ratio, which is, in simple terms, it just tells you, are the cells in the body using carbohydrates for their fuel, or are they using fats? Okay. So high number means the cells are using carbohydrates. Low number means they're using fats. And the group of mice that was on the alternate day fasting plus the treadmill training are using fats, which makes sense. Their ketones are higher. And then also, on the fasting days, both the sedentary and exercise animals have their burning fats on the fasting days. What about humans? This is a study from 1967. Very simple. Just give subjects, and I think there are about 20 subjects in this study. They had them fast for 48 hours. So at time 0, they stop eating for 48 hours. Then they measure ketone levels, and I'll just focus on the blood ketones here, which is mainly a chemical called beta hydroxybutyrate. Okay, so within 12 hours, there's already an increase in the ketones, keeps going up through 48 hours. Then they had the subjects drink sugar water. And what you see then, as soon as they consumed the carbohydrates, the ketones plummeted. Okay, so that's what happens. If you eat 3 meals a day plus snacks, the ketones always stay low.
Ketones are fundamentally good or bad?
In this scenario, they're good. There's a medical condition called ketoacidosis, which is a medical condition, which is a different situation. And so, and yeah, okay. Right. So this just quickly what happens is how ketones are produced. The fatty acids are released from the fat cells when you're fasting. They go into the liver. They're converted to beta hydroxybutyrate. It can be used to generate ATP in neurons through the TCA cycle, Krebs cycle. Now, one of my postdocs, Christina Morosi, she found that, as I'd shown, exercise increases ketone levels and decreases glucose levels. But she also found, as others had, that exercise increases BDNF in the brain, and that there's a correlation between the circulating ketones in the blood and the level of BDNF in the hippocampus in the brain. Higher ketones in the blood, higher BDNF in the brain. So that was interesting. So what Christina did then, she took cultured nerve cells from the brains of rats, and she simply exposed those cultured nerve cells to the ketone directly and then measured BDNF levels. And what she found is that when she had the nerve cells in presence of low glucose levels, which is actually low, close to low physiological, she saw that the ketones cause a tripling of the BDNF levels in the neurons. However, if she exposed the neurons to the ketones when glucose levels were high, she did not see the increase in BDNF. But the bottom line here is that the ketones can stimulate production of BDNF, this protein that's very important for learning and memory, and that's known to be increased in the brain with exercise and energy restriction. As an aside, and we talked about depression with Mr. Cummings, there's strong evidence that the antidepressant effects of exercise and the most commonly used antidepressant drugs, like Prozac and Paxil, these serotonin, norepinephrine reuptake inhibitors, the antidepressant effects are mediated, that is, require BDNF. Okay? So, exercise is good for antidepressant effect. We think it's also good in, it can promote synaptic plasticity, maybe even increase number of synapses. And okay, so what about Alzheimer's mice? Many years ago, we generated a model of Alzheimer's disease that have plaques and tangles, and it's been widely used. There's several thousand citations of studies in this model now. What we did in this study, we took these Alzheimer's mice and we kept them on the normal diet. That is, they can eat as much as they want whenever they want. We had another group, we reduced their daily calorie intake by 40%. We had another group on alternate day fasting. And then we started them on the diets at a pre-symptomatic stage. That is, before we could detect any learning and memory cognitive deficits. And then we maintained them on the diets for a year. which is half the lifespan of a mouse. And then we tested their learning and memory. These are the pink line is the Alzheimer's mice on the ad libitum diet. So this is the mice that ate as much as they want, the Alzheimer's mice throughout their life. They don't have a very steep learning curve in this test. This indicates their learning and memory is impaired. They don't decrease the time it takes them to solve this maze. These mice down here are the Alzheimer's mice on alternate day fasting or daily calorie restriction. They performed as well as mice without Alzheimer's disease, which is the non-Alzheimer's disease mice on the ad libitum diet. So this suggests that alternate day fasting or calorie restriction maintaining relatively low energy intake throughout life may forestall the onset of cognitive impairment in a mouse model. We also found recently in a collaborative study with Richard Veach here at NIH, who developed a ketone ester, which is the same ketone I've been talking about, the beta-hydroxybutyrate, the one that increased with fasting. It stimulates BDNF production in the brain. In the same mouse model of Alzheimer's disease, we found that even when the mice eat as much as they want, whenever they want, if we give them this ketone to increase the ketone in the blood, it improves their cognition, and also interestingly, it reduces their anxiety level. It turns out chronic anxiety is often a precursor to depression, and a lot of patients with Alzheimer's disease tend to have anxiety-like symptoms. Okay, finally, I'm going to briefly talk about mitochondria. We're starting to study at the molecular level what's happening in brain cells beyond BDNF production that may protect them against age-related cognitive dysfunction and Alzheimer's disease in response to exercise and energy restriction. And in this paper in Cell Metabolism published last year, we found that there's an enzyme in mitochondria called sirtuin-3. It's a protein deacetylase that removes acetyl groups from lysine residues. We found in this study, if we put running wheels in the cages of mice, that it will increase the amount of the SIRT3 enzyme in the mitochondria of nerve cells in the brain. We also found that if we stimulate glutamate receptors, glutamate's the major excitatory neurotransmitter in the brain. It's critical for learning and memory. And many of the neurons, well, all of them, I guess, that degenerate in Alzheimer's disease have glutamate receptors. So right now, because we're thinking about this, our glutamate is being released from presynaptic terminals. It's exciting cells. So these nerve cells in our hippocampus are being excited now. That's a good thing. It increases BDNF levels, but we're also finding it increases the SIRT3 protein in the mitochondria. And in this study, we showed by using mice that have a deficiency in SIRT3 that, and by using gene therapy to increase the amount of SIRT3 in mitochondria and neurons, we showed that SIRT3 can protect nerve cells against the kinds of stresses that we think are occurring in Alzheimer's disease. Metabolic stress, that is problems with energy production, oxidative stress, accumulation of free radicals and damage, and then cell death. And we found that two of the proteins in the mitochondria that are affected by SIRT3 are superoxide dismutase 2, an antioxidant enzyme. So exercise through SIRT3 will increase SOD2 activity and increase the ability of the mitochondria to remove free radicals. We also found that SIRT3 will protect the mitochondria by deacetylating the cyclophilin D, which is related to protecting against cell death. I'm going to skip this. Right. Okay, so to summarize this, exercise, fasting, and keeping your nerve cells active. All three of these increase activity in neural circuits, and we've shown that through these pathways involving calcium, kinases, and transcription factors, which I didn't really talk about much, including CREB and one called PGC1 alpha, these diet and lifestyle factors can increase the number of mitochondria in neurons. We published data on that a number of years ago, and also strengthen the mitochondria, increasing their resistance to stress. And that may then promote the function and even formation of new synapses. Also, the elevation of 3-hydroxybutyrate, the ketone, can boost the energy for the neurons, and that may be protective. So now I'm going to briefly talk about humans, what we're doing in humans. So I mentioned fasting will result in mobilization of fats from the fat cells, production of ketones. But fasting also does several other things that we think may protect against a number of age-related diseases. Reduced inflammation. This has been well documented in animal studies, but also in human studies. Reduce blood pressure, reduce resting heart rate. We showed that similar to in exercise training, intermittent fasting reduces resting heart rate and blood pressure and increases heart rate variability. So it's good for your cardiovascular system. Those are some examples. So what data do we have from humans? Here's just a few studies, and these are our studies. There's studies from a number of other laboratories over the last 5 years who've been coming out in increasing frequency. We did a small study a decade ago in asthma patients where we took overweight or obese asthma patients. We put them on a diet where every other day they ate only 500 calories. So that's a huge, change. But we were able to have 80% of the subjects make it through 2 months on this alternate day eating only 500 calories. So on those alternate days, their ketones are up, and then they're down, and then they're up, and then they're down, kind of like in the mice model. And we documented that in this study. But we found that they lost weight, their asthma symptoms improved, their airway resistance improved, and then we measured this is a change in weight. Interestingly, particularly by several weeks to a month, in self-rating score, their mood improved. They were losing weight and feeling better. Their hunger scores maybe went up a little and then quieted back down. And then this is a peak airflow went up and stayed up through the 2 months. We measured, this is just a few of the things we measured in the blood. This is one marker of inflammation, tumor necrosis factor alpha. By a month of, not by 2 weeks, interestingly, but by a month on this alternate day fasting, if you will, the TNF levels went down highly significantly and stayed down through the 2 months. We also found that markers of oxidative stress went down with a similar time course. Ketones, we took blood on either the normal ad libitum eating day or the 500 calories a day at several time points. And as you can see, ketones were up on the days. And in this study, they were given shakes on those days. We knew exactly how much, and we could document that they were actually not cheating because their ketones were up. If they were cheating, the ketones wouldn't be up. And then that study, together with 2 studies we did with Dr. Michelle Harvey at University of Manchester in England. In this study, we took women at risk for breast cancer because of their family history and also they were overweight, which is a risk factor. And we had them go for 6 months on a diet where 2 days a week they only ate 500 calories. And we also had a group that reduced their daily calorie intake by 20%, but ate 3 meals a day. And kind of the take-home message was that the women on what's called the 5-2 diet lost more belly fat and had greater improvement in glucose regulation, increased insulin sensitivity, more so than the women who counted calories at every meal. And that led to so this led to like an explosion of interest by the lay public in these intermittent fasting diet. This alternate day diet book was written by Jim Johnson, who's the first author on our asthma study. He's not at NIH, so he can make money from royalties. I can't. So I haven't yet written a book. I have given a TED Talk. If any of you know about TED Talks, if you're interested in 16-minute talk, that you can find that easily. The fast diet or these 5-2 diets, that's all based on the studies we did with Dr. Harvey. What Dr. Kapogiannis is doing now with my cheerleading and hopefully some scientific input, he has a study ongoing where he had subjects between the ages of 55 and 70 who are actually obese, this should be obese, and insulin resistant, but don't have diabetes. This is a group of individuals that, based on a lot of data, has increased probability of developing dementia. And what we're doing is we're randomly assigning, and we're about halfway through the study in terms of the number of subjects that have gone through it. They're randomly assigned to either the 5-2 diet, 2 days a week eating only 500 calories, or control diet, which is advice for healthy eating. And then before they're started on the diet and 2 months after, they have a battery of cognitive tests, psychological tests, functional magnetic resonance imaging to look at nerve cell network activity in their brains in the resting state and while they're doing some cognitive challenge. Dr. Kapogiannis is also doing spinal tap, which is just like a needle prick. The way he does it, it's no complaints from the patients. But in those subjects who will agree to the spinal tap, the reason we're very interested in the cerebral spinal fluid is many of the neurochemicals that we've measured in the brains of the rats and mice that change with intermittent fasting or exercise, we're going to measure those in the cerebrospinal fluid of the living human subjects. BDNF, markers of oxidative stress, inflammation, maybe things related to energy metabolism, and so on. So that study's ongoing. It's on clinicaltrials.gov. So we're moving forward. And
so can I say one
yep.
word about this?
Yep.
So today we had subject 13 who completed her participation. So today we had a participant who completed this study after 8 weeks of being on it. And what she shared with me is that the amazing clarity is her work that she experienced on the days that she did the fasting. She said it's unbelievable. She never felt so clear in her life mentally.
So these are the, there's a lot of anecdotal data on this regard. And in my TED Talk, I gave some historical perspective on how Plato, in his writings, claimed that he did his best thinking when he was fasting. And there's other examples, some quotes like, I can't remember this, Mark Twain saying that a little starvation can do more for your health than any doctor can do with a prescription, and so on. But there's a lot of anecdotal data. I get a lot of emails from people who claim and we know if you eat lunch, particularly if you eat carbohydrates, you feel kind of sleepy afterwards, so now we're testing this in a clinical setting in randomized controlled trials, which are what's needed to get data and statistics to see if a lot of these self-reports and anecdotes turn out to be true. Okay, and I think I'm pretty much done. Oh, okay. This is it's not a policy statement. It's just a statement of reality and data that there's a lot of things that can be done, we think, to improve health at the levels of medical education. There needs to be more emphasis, this is my personal opinion, in medical school on on prevention and risk reduction and how to prescribe diets and follow up with them, how to prescribe exercise and follow up, not just tell a patient you need to get more exercise and cut back on calories, but actually give them a prescription, follow up with social media, text messaging, and be a cheerleader for their patients rather than wait till they have diabetes and then prescribe a drug. We know in the case of diabetes, it can be largely prevented. Not completely, but largely prevented through diet and lifestyle. So physicians, parents, get your kids started on good diet and exercise habits, even if they're not your own habits. Okay, and then, nobody makes money from intermittent fasting. Maybe some people make a little money from exercise if you have a membership to a gym or something. But so there's a lot there's two books I think that people would be well advised to read. One is called The War on Science, which is a problem that people ignoring data or taking anecdotes as being representative. But there's also one called The Attention Merchants. The Attention Merchants. And it's about how advertisements have controlled the behavior of humans. Smoking's a good example, right? Finally, we have somewhat of a handle on smoking, but it took a lot of effort and policy changes. And now we're in a situation where people are overeating and becoming obese, and the food industry isn't very helpful. The pharmaceutical industry, there are drugs that we need, but on the other hand, drug companies don't make money if people are healthy, right? So, in a kind of cynical way of thinking, but there's some underlying truth to it that maybe the way the American system is set up, we want people to get sick and then treat them symptomatically rather than trying to help them avoid or reduce their risk of becoming sick in the first place. So that's my last slide. And that's, I'll just say, we practice what we preach in my lab. This is, the NIH has a relay race every year on this campus around buildings 1, 2, and 3. And last year, we set the course, not we, my runners that I coach, which is true. I guess none of them here. They may be listening through the internet now. But we smashed the course record. Actually, I think it may never be broken again with this group, because we smashed it by 40 seconds. So when I recruit, so these 3 are post-bac. No, all 4 of these are post-bac fellows. So when I recruit post-bacs, we have the database. I search for neuroscience. Is their GPA above 3.5? Then I put in cross-country, track, and field. But there's a scientific reason. I know if they're runners, BDNF levels are going to be up in their brain. They're going to be functioning cognitively well, and they'll do well in the lab, which they're doing well in the lab. So thank you very much.
So we have some time for questions.
Yes, I can. Has there been any study, are there any detrimental effects to any organs of the body from fasting that you've been able to identify?
When? What? I'm good. Oh, yeah, I've got a mic. Never mind. The short-term fast that I'm talking about, not yet. We haven't seen any adverse effects in individuals that are either overweight but otherwise healthy, or actually, but mostly So we haven't seen any negative effects, but elderly, frail people and very young children, I wouldn't think it's probably a good idea. But again, getting back to the evolutionary aspect, we're geared to this kind of eating pattern. So in a sense, it's similar to exercise, that you can overdo exercise somewhat, and there are certain populations, although it's a small number of groups of people, that maybe you can overdo exercise. So it's kind of a similar scenario. Longer term fast is a different story. You know, there are people who will, every few years, they'll fast for a month, you know, water fast. And that's something that probably you really need to consult with your doctor before you do something like that. But these short, you know, few days eating only 500 calories.
Have you shown any benefit for the people who compress their eating to within a certain number of hours of the day?
And in humans, the studies haven't been done in humans. They are going to be done. There's an investigator at the Salk Institute, Dr. Sachin Panda, who published a lot of data in animals. He's starting to do human trials. We know from the standpoint, there's evidence from the standpoint of biomarkers, you know, ketones, insulin sensitivity, and so on, that it's better than eating 3 meals a day plus snacks. And the animal study is very striking beneficial effects.
A comment and a question. The comment is why you are limited to 70. I want to participate in clinical trial. I am above 70. So you should change that policy. Because as
you need to get younger. You can lie. You can cheat.
No. I cannot participate in the clinical trial. That's what I'm saying.
But you're not obese.
Well, I participated in the obesity phenotyping for 5 years. I learned all these things because I was doing it. So the second question. So what is the mitochondrial function with respect to the ketogenic diets? How much calorie are they making? Are they making it through the TCA cycle, glycolytic pathway?
Yes, it's TCA cycle. So the ketones metabolize to acetyl coenzyme A, then it goes in the TCA.
So how many calories per gram?
I don't know the exact answer. I should, but I don't. So you got your cell phone? You can look it up.
Okay.
So my question is about the rat model that you were showing, and you said that you had it on one day or alternate fasting. But did you study the moods of the rats? Because why I asked that is I didn't do an experiment on myself all to give you data, but I've noticed that either during a day or parts of the day when I have not taken intake of food all, I see that I get headaches.
Yeah.
And so I didn't do in long-term experiments. I can do that.
I'm glad you asked that. That's something I wanted to mention, but I didn't. So in the human studies, we find that the subjects, when during the first 3 weeks, even up to a month of eating only 500 calories a couple days a week, they have the same kind of complaints. Once they get beyond 3 weeks or months, this seems to be like the common time interval, they're adapted to it. They're no longer hungry. They no longer have the headaches. Also, and this is kind of self-reporting, women seem to get headaches more than men. And however, if they drink caffeinated beverages during that time where they're fasting and not eating much, they don't tend to get the headaches as much. So we think it's kind of, again, analogy to exercise. If you've been sedentary and you go out and run 5 miles, you're not going to feel very good until you get in shape. If you've been eating 3 meals a day plus snacks your whole life, and all of a sudden, so you could ease yourself into it. Maybe to start 1 day a week, cut down by whatever 30-40% calories, do that for a month, and then you can kind of build up to it, just like you do with exercise training, build up until your system gets adjusted to it.
So, Mark, let me ask
Dimitrios,
you.
did you?
Oh, are there any?
Okay. Oh, and then in the animal studies, but this is very interesting. We have unpublished, we have a paper submitted now. It's very interesting. So we can measure indicators of anxiety. We have certain tests for anxiety-like behaviors in animals, and we can also look at activity of neurons in a brain region called the amygdala, which is involved in anxiety. If we take a mouse that's never fasted before and we deprive it of food for a day, there's increased activity in neurons in the amygdala, and they have increased anxiety-like behavior. However, if we put them on an alternate day fasting diet for a month, they actually have reduced levels of anxiety once they're adapted to it. And so that's, even in animal studies, we have this evidence that it's a big change in not only their body, but their brains haven't adapted to it.
Mark, let me ask you, NAD leads to the deacetylation activation of SIRT3. That's
right.
Showing.
Yeah.
Now, that's all AMPK dependent. And nowhere in your diagram do you find this rate-limiting kinase, which is what really is the metabolic sensor.
Yeah.
So my question is this effect of the intermittent caloric restriction and so forth really mediated through the LKB1 AMPK pathway leading to the sirtuins? Because I don't think anybody knows that the sirtuins endogenously are activated. They're activated through this deacetylation process.
Yeah, that's a good point. So this has been studied extensively in muscle, skeletal muscle, and particularly in relation to exercise. There's a protein called AMP kinase that plays a critical role in setting in motion gene expression programs that make your muscles stronger, increase the number of mitochondria, and so on. There's one of the transcription factors is PGC1 alpha, which is downstream.
It's the same thing in the
Right.
liver.
So we find that the liver's not very important, is it?
Depends who's paying the bill.
But this hasn't been studied much at all in neurons, a little bit, and it's a very important question. What we do know, though, is if you can boost NAD levels in the neurons by giving animals nicotinamide riboside, it's good. It's neuroprotective, and there's clinical trials in progress or planned of NAD boosting approaches in subjects with mild cognitive impairment or Alzheimer's disease. You know,
what is the role of telomeres in this whole process?
well, that's an interesting question. So she's asking a question that's related to basic mechanisms of aging, and telomeres seem to be particularly important in cells that divide, because as our cells divide and turn over in, say, your intestines or blood cells, right? They get renewed. As we get older, the telomeres in the cells get shorter and shorter, and they can reach a critical stage of shortness that can cause a lot of problems. However, nerve cells don't divide. As far as we know, their telomeres don't get shorter with aging. However, it turns out that DNA, at the ends of the chromosomes, the telomeres, that DNA seems to be prone to damage by free radicals. So your question is good. We don't know much about telomeres and brain aging. Don't know much about it at all.
I wanted to ask two different questions. If the mice or the humans who are in the trials do this for some period of time and then they stop, does the benefit persist? And I mean, because if you can do it for anyway. And my other question is, in the old days, you used to hear about the Atkins diet, and it was supposed to promote ketones.
Yep.
And that was like the diet where you basically didn't eat carbs and you ate a lot of protein. So that sounds like a unpleasant, but less unpleasant than alternate day fasting.
Yeah. So the ketogenic diet, that the Atkins diet will increase ketone levels, so that could be good for your brain, should be good for your brain. However, a lot of the fats in the Atkins diet may also be pro-atherogenic, the saturated fats. One way to increase ketones is to consume what are called medium chain triglycerides, which are anyway, they're kind of an immediate precursor to the ketones and are thought not to promote atherosclerosis. So I would say that the only downside of the Atkins diet is, I guess if you watch what fats you're eating carefully, then that can be good. And also if you're fasting, if you're doing, like I mentioned, eating 500 calories a day, if on those days you eat fat, essentially low or no carbohydrates, you won't be as hungry. Have perceived that you're hungry. So that's another aspect of that. Then your first question. See, I'm getting my short-term memory's gone already. Oh, in animals, it depends. As far as extending lifespan, yes. If you put an animal on calorie restriction, energy restriction for 6 months, let's say early in its life, and then put it back on normal diet, it will live a little longer. Not as much as if it would have. However, in some things we measure, like insulin sensitivity, or I mentioned blood pressure and resting heart rate go down. In our studies in animals, within a few weeks of going back to the ad lib diet, the blood pressure, resting heart rate are back up. So again, going back to exercise, it's somewhat similar. If you've been exercising and you quit exercising, probably you've accrued some benefit in terms of your longevity for the time period you've exercised. But if you stop exercising, then so it's kind of diminishing returns.
So wonderful talk. Thank you.
Yeah.
My question is, in certain parts of the world, for example, rural sub-Saharan Africa, people eat low levels of calories, maybe 1,000 calories a day, maybe sometimes just 1 or 2 meals per day. And I was wondering if you're aware of any epidemiological studies showing lower incidences of AD compared to people in the West.
I don't know about AD. I know about cardiovascular disease. They have much lower risk. But
just one clarification. We're talking. Yeah. An important clarification that these concepts don't involve nutrient deficiency. So these are calorie deficiency, but overall, whether you say it over a circle of a week, and definitely when it comes to stores of essential nutrients, these are not depleted in these patients, whereas in the sub-Saharan Africa populations who are chronically malnourished, they will have depletion of all vitamins and everything that you can imagine. Whereas in our patients that we test, we don't. This also a study that there are many different concepts about how to get to this intermittent fasting. Recently, I heard about and saw data about a study where every few months they do a period of 5 days, every 2-3 months, period of 5 days, and this seems to have a great response in lowering blood pressure, cholesterol, insulin resistance, and all sorts. So definitely the intermittent fasting is a great concept. What's the best way to implement it is up for debate, and there are many.
But Dimitrios, do you know of any studies of Alzheimer's disease, the incidence in some of these African
with life expectancy being in the so as low as it is, I don't think that it would be any valid. So they die from other causes.
There was one comparing the Ibadan Indianapolis study comparing West Africans and African Americans in Indiana, and we're funding another.
Good. That'll be interesting.
All right. Well, listen, I want to thank both of you for a very exciting.
You're welcome. Good, great questions.
So,
You are a good example.